I mean, this was surprising to me even. Did you know the NHS waiting list for elective treatment in England has been growing since 2013 and almost tripling in size over the decade to currently 7.7 million patients waiting on the elective list?
That is unbelievable. Hello and welcome to another episode of the Dev and Doc podcast, where doctors and developers talk about AI in healthcare. I am Željko, I am the developer, and with me is Josh.
I'm the doctor, I'm a neurologist and AI research fellow in King's.
Great, so what's our topic today?
Topic for today is very interesting. It is talking about the state of the NHS, and we'll go deep into that. And given that this is the state, whether it would be ethical or not to just use a large language model to try and solve some of the issues that are ongoing.
Very nice. I think this is a tricky topic. It is not easy to decide should these models be used, but also once we learn a bit more about the state of the NHS, maybe there is nothing else to do. Maybe they have to be used.
Yeah. Look, let's start with a little anecdote, shall we? As a training neurologist and doctor in the National Health Service in the UK, I have had over 7 years of experience working firsthand on the front lines of the NHS. And I have spoken to my colleagues and my seniors as well. The state of the NHS from a personal perspective is that there are more and more patients to be seen. There's more pressure than ever, and COVID has definitely not helped that. The patients that are coming in, because in the UK we have an aging population, meaning that we're starting to get more and more older people and less younger people within the balance of the population, which means that patients coming in tend to be more elderly, have multiple comorbidities, meaning that they're very complicated to treat, because sometimes managing one condition can mean potentially increasing risk of another, and there can be drug interactions as well. So that's my experience, and working in the emergency departments even last week, it got so busy where it went to the point where I was seeing doctors treating patients in corridors and people ambulance staff waiting for hours and hours with the patient because they can't leave the patient right until they have a proper bed and they're seen by a doctor. So ambulance staff have to wait there in the corridors with them whilst a nurse or a doctor is speaking to them and trying to get some kind of preemptive treatments arranged.
Was this, how big of a difference it is? Was this also the same? I don't know if you're comparing, how was it 6-7 years ago to today? How big of a difference are we talking about?
6-7 years ago, I was working in a slightly different hospital in a different region in Manchester. It was still bad, but definitely post-COVID, I don't know what it is. It feels like it's busier, and because there's a lot more precautions as well around infections and things, which there should be, to be honest. But even going in between patients to patients, we are more conscious of wearing things like masks and gloves. And imagine if you have to see 20 patients in a day, and each time you see someone, you have to wash your hands, you have to look for the gloves, you have to wear the mask, and then you have to bin it after. Each bit adds on another few minutes here and there, and it's just getting busier. And speaking to my consultants who have been working for decades and decades in the 80s and 90s, they definitely say that it is getting busier. It's getting busier and busier, and there's more treatments for patients now as well, which means there's more to consider. You have to spend more time with patients, and also there's kind of more there's more guidelines and there's higher litigation as well. So everything is more, it's good because it forces you to work at a probably higher standard than you had to 30, 40 years ago. But it just means increased pressure when you're seeing patients and increased time having to spend with each patient.
And how was the change like during COVID and after COVID? Like when did COVID really make a big difference? Like how was it basically also like during COVID?
Yeah. So COVID affected the hospitals and the staff in two ways. One way is obviously the stuff which you see on the news and on the, in any like drama or documentary you've seen. It was treating loads of very sick, elderly, comorbid patients with COVID. They came in with something called COVID pneumonitis, which means that in some patients the lungs can get really inflamed and they struggle to breathe, and then you need to put them on a ventilator. And that's usually the biggest cause of death in COVID. So that's one thing, the acute sense, and there was a massive hospital burden at the time. But what that also meant is that elective patients, i.e. those who were not acutely unwell but waiting for routine checkups or reviews by doctors or surgeries, so things like knee replacements, hip replacements, seeing a specialist for something that's not acutely life-threatening, like, I don't know, a migraine or a headache. All of those things were cancelled during COVID, which means that the list has built up, and we're now feeling the aftermath of that. And this is called elective, right? Elective patients. And maybe we can put some stats to this. This might be a good time to maybe go off the personal and maybe just put a bit of numbers to this elective burden now that is sitting on the NHS.
And wait, I just have one more question here. Like, is one of the reasons also basically because a lot of patients also, like, the state deteriorated just because you maybe delayed something for too much? Like I assume there is a risk of delaying things too much because currently there is no time, so you delay it because it's not urgent, but because you do it later, it is worse than doing it now.
Yes, I mean, prevention is the best cure in many ways. It's hard to model and it's hard to understand the impact of delaying kind of elective, non-urgent appointments. But, it's very hard to say what impact it has had. It would definitely have had an impact in terms of people's quality of life, maybe suffering with more pain and discomfort before being seen by a clinician. Whether that translates to people getting sicker and having life-threatening events is something that I can't answer, and something that's very difficult to answer.
Oh, okay. Yeah. We would need some stats to back it up, or
exactly
some way try to model and understand. Yeah, that makes sense.
Okay, so speaking of stats, why don't I just share an interesting article I saw. So this is the Health Foundation. I don't know much about them, but I know it's kind of an independent charity that looks at healthcare in the UK, and they decided to have a look into the NHS waiting list and kind of the impacts that COVID has had. So for those of you who don't know, I mean, this was surprising to me even. Did you know the NHS waiting list for elective treatment in England has been growing since 2013 and almost tripling in size over the decade to currently 7.7 million patients waiting on the elective list?
That is unbelievable. If you told me, to estimate a number, I would say 100,000. I don't know, 500,000 maybe, but I'd be like, oh, that's a high estimate. 7.7 million?
Pre-pandemic, it was 4.6 million, and post-pandemic, 7.7 million. The waiting list has grown very sharply.
But it's also interesting that it didn't start during the pandemic. Like you mentioned that these started in 2013, so we had some slight problems even before the pandemic.
So keep in mind the estimated population in England is around 56 million currently, and 7.7 million are waiting. So that's a substantial proportion of the population.
Yeah.
And the other thing is the strikes, right? In case for the non-UK listeners, there has been a lot of industrial action, strikes from the doctors in the National Health Service in the UK, because we are worried about the kind of working conditions, the erosion of pay, and the loss of doctors to other countries like Australia and New Zealand and the US because of better conditions there. So there have been a lot of strikes, and the government tends to say that this waiting list is because of the strikes, and obviously it's not. As we've just highlighted, there are millions and millions of people waiting already. And here I just wanted to quickly just show you this graph, this nice little modeling graph they made actually. Okay, so here we have a modeling of the waiting list, and you can see here, it's very nice actually. So you can see when COVID-19, around February, March 2020. So here you can see already in January 2018, there were around 4 million, and it was steadily climbing. And then during COVID, it dropped a bit, and then now it's kind of gone way up. So all these patients, 7.7 million, are waiting. I mean, the number is just baffling. Like, I don't know what you think about it. I mean, it's a crazy statistic, isn't it?
No, exactly. I would not have believed it. So if you told me like 7.7 million patients are waiting, I would be like, impossible. The UK is not that big to have that many patients waiting. But
yes. And this is where another interesting point comes in. A lot of these patients may be ghost patients.
Okay.
And this is very interesting from a data perspective. Why are they ghost patients, you ask? Because, okay, let me give you a scenario. Let's say a patient has a really bad headache, okay? And the GP doesn't know what it is, so they refer them to a neurologist. And let's say the waiting time is, I don't know, 3-4 months. Within that time, they might have gotten really bad. The headache might have gotten really bad, and they might have come into hospital through the emergency department. And they may have scanned the head, and they may have asked for a neurologist to see them there. Now they may have been seen, and they may have been diagnosed or treated. However, that appointment may likely still be there.
Okay, so this is, you are saying the IT system is also a mess, and when someone comes in through a different route, we don't know that they came in. Exactly.
Or a patient lives in one area, and then they're referred to the local hospital, but then whilst they're traveling somewhere else, that they get seen somewhere else. So here in this article, they've said the waiting lists have been a fact of life since the inception of the NHS. And with statistics on the number of patients waiting for routine hospital appointments dating back to 1949. And here's another interesting thing I found. On the BBC website, there is a NHS hospital waiting time tracker, which is really interesting. So let's I've put in the postcode for King's College Hospital, the trust that we work in, and look at these stats. These are astounding. So how often are ambulances queuing outside the emergency department? So here it says ambulance waiting 30 minutes or more, which is what I described. So they have to stay with the patients until a staff takes them on. It should only take 15 minutes, but 27% of ambulances arriving have to wait more than 30 minutes before a nurse or a doctor kind of takes over the patient. This is very wasteful. So a third of ambulance staff essentially have to just stand there and wait instead of going to pick up the next emergency patient. And then here, how long are A&E wait times? So the target set by the government is that, patients should not be waiting for more than 4 hours in the emergency department. Now, here you can see 40% of patients breach that 4-hour wait time.
To not make it any darker, because this seems like I'm not very hopeful by reading and listening to this. It is basically like we have some difficulties that we should look into solving. And I do think, just to address a bit the brighter side, because a lot of these statistics are not looking that well. A good thing is that in a lot of these graphs that we have seen, the trajectory is starting to go in a bit down the last year. So we are seeing a bit of a reduction. And I do think, like, I still somehow feel the need to say that, like, every doctor, every researcher, every clinician, every healthcare professional is still doing everything they possibly can to help patients. So it's just like, I don't know, I feel like after listening to all the bad sides, I feel like I have the need to really say that everyone is really trying to help. And whatever I know, like, hundreds of doctors and also as many researchers here in King's College Hospital that are really trying their best to help. And I think this is also where the current AI revolution will hopefully improve this, and with the right incentive from the government. Last week we were talking about regulations, and we hope that if this is done properly, it will not slow down the progress, but it will speed it up, and we will have a resolution in these waiting times.
We are all trying our best. And the other bit of light is going back to these ghost patients. It's unclear how many of these are ghosts. And like you said, because the data is not communicating with each other, sometimes the patients have actually been seen in some regard and may not need that appointment, but the data is not communicating. And also, the other thing is, when doctors are very busy and let's say they've seen a patient in the clinic, sometimes they don't put on the system actually what the follow-up should be. So when you see a patient in clinic, you have a few options. You can say you want to see them again and there's problems going on. You want to see them again in a month or 2 months or 3 months or 6 months to a year. Or you can say they're kind of well, so let's discharge them from this clinic and they can kind of be followed up from the GP perspective. So that means I don't need to see them again in that regard. But it's not always clearly coded. That is I might sometimes, if we're busy, we might just type it in on the notes, but we don't actually click the data tick box to tell the system what happened. So there are people kind of that's full-time job is to go through those notes and to try and find what the outcome was and then action that. Yeah. So a large proportion of patients actually have probably been seen, but just haven't had the outcome actioned. So that's another ghost patient.
And some systems, in fact, you and I have made are helping these. Like some of the tools we have made are really there to go through the records, find what was written, so extract from free text and then try to synchronize or at least suggest to
we have built this model and we're validating it right now. And if it works, we suspect it can probably cut off at least 20 to 40% of those ghost patients.
Wow. Okay.
So that's substantial.
Yeah, that is very good. But another interesting thing I wanted to touch upon here is when these patients need to wait, so when the waiting time is really going into months, it is inevitable that some of them will turn to other methods. And those other methods can be really Googling their symptoms. trying to understand what is happening, trying to educate themselves, and more recently to use ChatGPT to help them. Doesn't have to be ChatGPT itself, but any one of these large language models to help them. And I'm really interested, like, what's your take on these? How do you see that?
So that's a very interesting topic, because since ChatGPT came out, there have been quite a handful of articles saying that ChatGPT diagnosed me. There's an article here. ChatGPT diagnosed the boy after 17 doctors over 3 years couldn't diagnose the boy. Things like this. So, but obviously it's very biased, because you only hear the success stories, right? You wouldn't be hearing someone make an article if they consulted ChatGPT and it gave them terrible advice and they ended up running to the emergency department and all the doctors just rolled their eyes and it was completely fine. You wouldn't hear about those things. We've talked extensively about the capabilities of these models, and they tend to be quite good in general, but they make a lot of mistakes as well. And the problem is you don't know when it's making a mistake. That's the issue.
Yeah, but like, what if the people are using these models simply to educate themselves a bit? So, I mean, having the model diagnose me, to be honest, even means very little. Because if the model diagnoses me, what can I do with that? I still go to my doctor and then speak with my doctor about it. But I think, like, what do you think about people using it to educate themselves, to learn more about the symptoms, about the disease, about their condition, basically?
The problem is, one symptom can signify tens of hundreds of diseases.
Yeah.
And we've tested this, right? So, if you give it a symptom of chest pain, which we see very frequently in the emergency department, like worst case scenario, it could be a heart attack or a clot in your lungs, or it could be just you're feeling a bit anxious, or it could be you're playing golf the other day and you just pulled something. That's the problem. Like, it's very hard for ChatGPT to know your entire history and actually balance what is going on and what the likely diagnosis is. It will give you a list of diagnoses that it could be, but it doesn't really understand the probability of, because when you diagnose as an art as well as a science, I don't feel like it can fully grasp the gravity of certain symptoms and what the diagnosis will most likely be.
Okay, I think that it makes sense to me, and I think you are looking at possibly very serious conditions. But I think and again, you are also thinking about what if it's an emergency. I think what many people have experienced is that, I don't know, I have some gastrointestinal problems. Call my GP, he tells me, oh yeah, there is a gastro appointment in 72 weeks. And in the meantime, you are by yourself. And I am 100%, not only am I 100%, but I know people who have used then ChatGPT to be like, okay, this is everything that was happening with me over the past 2 months. Is there some vitamins, minerals, probiotics, I don't know, something that I can take? And people are for sure doing this. Like, it is very hard to prevent this because that person is left on their own. We just said, like, NHS waiting times are so long, they have to do something. So I think, like, what we maybe should do is try to steer the people in the right direction, or at least try to tell them how to use it the right way. Because people are going to use it either way. And it is the ideal situation where we are saying, like, yeah, don't use it for that. It's not good. But that person is left by themselves. They have nothing else to do. I mean, they can sit and wait for the gastrointestinal stuff to pass.
Mm-hmm.
But if it's ongoing for 2 months, it will most likely not pass.
Yeah. So you're saying that given the waiting times and given the anxiety and the suffering that the patient's going through, they will likely use Google or ChatGPT anyway. And is there a way to educate / safeguard them using it?
Yeah, because for sure they cannot get prescription medications. I mean, that is impossible. But I don't know, ChatGPT will recommend them at some point, oh, try this herbal stuff. Or they will find that on Google. I mean, people have been using Google to diagnose themselves for years, for decades. And I think now the question is just like, is ChatGPT helping that? Or is it making it worse?
Yeah, it would be really interesting to see a head-to-head comparison to see what ChatGPT gives us recommendations versus just Googling your symptoms. But and we've talked about this in the previous episode, the problem is the distribution of data on the web is heavily skewed towards emotive diseases like cancer or, or stroke or things like that, heart attacks. So by nature, they're more likely to probably suggest those things and may cause undue concern for the patient. And, with your points about patients using different supplements or herbal remedies, that's also very dangerous, right? Because if the model says, okay, this doesn't sound like anything dangerous, just take some, I don't know, herbal remedies, and instead of seeing a doctor, you may actually, if it's wrong, you may have delayed your presentation and your diagnosis substantially.
But you are saying instead of seeing your doctor. Like, what if seeing your doctor is not an option, which is for most of these cases? Like, if a patient is waiting for that, as we said, we have 7 million patients waiting. So this is not instead of seeing the doctor. So basically, they call their GP or the emergency and they said them, oh, not urgent, everything's fine. You can do that in 3 months. In the meantime, very few people will just sit back and do nothing about that. I mean, I don't know.
Yeah. That's a very tough one because, look, so just to clarify, the NHS is actually great for acute care, for the emergency care. That's one thing that's been shown in many studies, that is very cost effective at dealing with acute problems. But going back to like the kind of long-standing chronic issues, that's where the NHS really struggles. Using Google or large language models is so difficult. Like, there's no clear evidence or guidance on this, and it's hard for me to advise one way or the other. But
would you...
Yeah.
Like, just if you're personally thinking about it, would you then say, maybe you cannot answer these, like, is it better not to do anything? Or is it better to do something? Or, I don't know.
I think it's... I understand what you're saying, and people will always use it. But it's not permissible to me as a doctor to use a device that is so convincing in its outputs that makes even occasional mistakes that could harm the patient, because obviously as a doctor you've sworn to do no harm, so that's one of the first tenets that you act by. And if ChatGPT or a large language model was a doctor, that'd be a terrible doctor, because they're giving such bad advice from time to time. And it breaches one of the fundamental roles of what a doctor or a clinician should be.
So again, I agree with everything. And my question in the end is just like, is there a way for us to make it safer? What advice, what what can we do to make it safer? Because no matter what we say, people are going to use it. And I don't know, is the right way to do it just to use both the large language models and Google to try to learn about your condition, to try to understand maybe your condition better, to try to...
Yes and no. It depends on the person's education. Like, what medical knowledge do they already have? You know, I've met some people who are very understanding of different health conditions, and sometimes it's cultural, but I've also met people that completely have no clue about their own conditions. So that's where it's dangerous, because you don't know what you don't know as a layman, and you don't know when it's giving terrible advice. I would say the best solution is what we've been trying to do, which is, you know, doing more research in this area, and also the grand aim of building a large language model that can be used by patients and clinicians alike. You know, we did fine-tune the NHS large language model, but the implementation is the problem. So then that boils down to regulators and funding and the just entire kind of AI infrastructure and health infrastructure in the UK. So it's all a cycle, right? What you're seeing when patients are using Google or using ChatGPT, that's just a manifestation of a struggling system, right? That's the problem.
Okay, no, with that I completely agree. So basically what we want is put more into research, put more into validation, everything that we were speaking about last week, which is the regulation around these models. We want to put more into AI safety so that we are sure at least these models that we put out, that they will do no harm, or they'll do as little harm as possible. So we simply need more validation of these models so that when people eventually end up using them, and they will, that we can be at least sure that they are doing very little harm. And
twofold as well, right? Twofold. So education, so validation of the models, yes, and education is so important for both the patients and the clinicians to know the limitations of the model and to understand, you know, when it's giving a bad output, when you should trust it and how you should interact with it. So that's kind of global AI literacy.
Yeah. And this is maybe a bit off topic, but do you think, or do you prefer when patients also get educated on their own disease, when they learn about their own disease? So like read medical literature, read papers. Is that something good or bad?
That is great.
That's great.
I mean, every patient, I mean, it's easier said than done, because it boils down to so much as like nature and nurture, like your mental capacity, your upbringing, your culture, like we said. But the patients that take an interest and an understanding in their own disease, I mean, they're gonna do better. Like, if they understand what the medication is for, how they should take it, and they take a proactive approach to health, that's amazing. Like, those patients are great because they ask the right questions and they take the right actions, and you know, that's important. So that's just going back to the education. It's important from a health perspective, and if they can have that knowledge and apply it to Google or ChatGPT, that is also great, because then they know how to interact with these models.
That's perfect. Basically, like, that's exactly what I was hoping to hear. I was not sure what are you going to say, but that's exactly what I was hoping to hear, because that also means that if we make these better models, if we make higher quality models that can provide real medical information, then it means those models can help patients. If they can provide like real data that can teach someone about their disease, the models should maybe then not be there to really diagnose or recommend stuff. There should be more there to educate and teach people about their condition, about what's happening, about everything. And then again, in combination with the doctor, it can be a perfect synergy.
Yes, that's perfect. And I think that pretty much encapsulates the state of the NHS. I think in this episode we've discussed a lot. And sorry about the doom and gloom and the personal anecdotes. But I do think, like Jauko said, there's a lot of good stuff happening in the NHS. And the clinicians, we're all working very hard to try and deliver the best care that we can. And with the help of AI, I think that can alleviate a lot of burden.
The developers are also working very hard. I just want to mention that also. Very important.
Jauko probably works harder than me, or as hard as, I don't know.
Yeah.
Jauko doesn't do as many night shifts.
True.
But yeah, look, I think that's it for this episode. We've covered a lot of interesting things, but hopefully this gives you a flavor about what's happening in the NHS and the importance of education.
I do think there are many good things happening, and the future is looking bright with the help of AI and basically with everyone working together, the doctors, the clinicians, the AI developers.
Yes, and that's it for this episode. So please like and subscribe, and maybe leave us a comment if you'd like about your experiences of the NHS, or whether you think patients should be using large language models or Google to consult for their own health and symptoms. We'll see you on the next one.
Thank you. Bye-bye.